It's Vivek's takes on Healthcare Unfiltered. Vivek, just so you know, you're the only person who comes on Healthcare Unfiltered that it's really your show. It's Vivek's takes, we call it. This is the third installment. We started doing this last year. We did ASCO 24, ESMO 24, and now it's ASCO 25, and we're going to do, of course, ESMO 25. Welcome to your show, Vivek's takes on Healthcare Unfiltered.
Thank you so much for having me, Shari. As always, pleasure and delightful and honor to talk to you as always. Thank you. Thank you for having me.
Well, thanks, my friend. And obviously, we all follow you on Twitter. We always look forward to some of your comments, and you've actually had several tweets that I read every single paper you put on because you really summarized a lot of things that happened at ASCO 2025. But we scheduled this time, me and you, after each meeting to go over not necessarily one paper or two papers, just like general highlights, general takes that you noticed at the meeting, trends, aspects, anything you would like to share with us. If there are specific trials you want to highlight, specific platforms, things of that nature. I just think you're very close to clinical translational research, so no one is better than you to summarize a major meeting like ASCO 2025 than you. So with that, let's get going.
Thank you. And again, as we always speak, right, ASCO for oncology is a Super Bowl for oncology, right? And this year was no less. So again, usually for the broad audience listening to your Healthcare Unfiltered, ASCO is the quintessential Super Bowl oncology meeting. Usually it's from May 30th to June 3rd or 4th in Chicago. And it's always in Chicago, features so many sessions, brings oncology, focused researchers, clinicians, industry, academia, regulatory authorities, everyone together. Again, this ASCO had around 450 oral presentations. I heard it's like 24 abstract sessions, 24 rapid oral sessions, clinical science symposia. Again, this time, it was a pleasure and honor to be a part of the, developmental therapeutics scientific abstract selection committee. Again, unbelievable, an unprecedented number of abstracts submitted. Again, the science is amazing. I would say, as Charles Dickens says, my famous favorite quote, it is the best of times to be as practicing oncology. Of course, this is the worst of times because we are able to do so much, but we are not able to implement it everywhere. So again, going on to ASCO, right? So many notable observations, practice-changing data. I think to break it down, we had from every tumor type, we had several practice-changing studies, emerging mechanism of action, right? I think oncology is moving on, right? We had surgery, we had chemotherapy, we had targeted therapy, radiation therapy, immunotherapy. Now we live in an era of antibody drug conjugate therapy and different drugs with new mechanisms of action, right? We are seeing PROTACs, like Western trispecific antibodies, of course, bispecific antibodies. There was a publication in New England Journal of Medicine becoming standard of care in second-line small cell lung cancer, but we are moving on to trispecific antibodies, radioligand therapies. Again, this reflects a shift towards innovative, trial designs.
Trispecifics. What are they targeting? What are the three?
So bispecifics. It's again. Let me tell you. It is like they are bispecific T cell engagers. So what happens is one the antibody has two parts. One catches the T cell, which is a CD3 part, and the other one targets the antigen, which is in the tumor. The specific one that was published in the New England Journal of Medicine was tarlatamab, which was a DLL, specific bispecific antibody. And this specific bispecific antibody again catches the T cells and brings them in close proximity to the tumor cells. And this DLL3 part, which is expressed in the small cell lung cancer cells, it attaches them and brings the immunotherapy to the, I would say, the directly to the cancer cells, thereby unleashing the immune system directly on the cancer cells. Again, the world of leukemia, right? In the last 10 years, we had many bispecific antibodies in leukemia and lymphoma, right? Blinatumomab has changed the landscape of ALL. not only in childhood ALL, but adult ALL. Huge, huge, because usually adult ALL patients don't do well, and childhood ALL patients are cured. But this has been transformative and revolution in liquid tumors. Solid tumors, we are seeing that. We are seeing all these bispecific antibodies come in, and now we are moving on from bispecifics to trispecific antibodies, right? So again, that's where we are. Again,
with the trispecific, you're targeting two antigens on the tumor cell and the T cell.
Yes. Trispecifics, it could be like trispecific NK cell engager. Yeah, but trispecifics, you're targeting B cells, NK cells, and the tumor.
Any examples at ASCO of trispecifics that piqued your interest?
Oh, absolutely. I think there were several of them. In fact, there was a DLL3 trispecific antibody that was presented, and there was also a prostate-specific trispecific NK cell engager and a HER2 trispecific antibody that was also presented in ASCO. Again, beyond that, we are seeing these PROTACs, right? PROTACs, we saw like several practice-changing presentations. In fact, one of the PROTACs, made it to several of the oral sessions for breast cancer. PROTACs, for the broad audience, right, are small molecules designed to bind both the target protein, in this case, in breast cancer, the ER, the estrogen receptor, and an E3 ubiquitin ligase. So this is an enzyme that marks the proteins for degradation. So again, two of the PROTACs that were presented as oral presentations and also published in major journals, one like in NEJM, the vepdegestrant. Again, it was called, I know that as ARV-471 from the phase 1 studies. Again, now it has a name. The trial name was VERITAC-2. It was an oral PROTAC estrogen receptor degrader. It showed significant improvement in median PFS, 13.9 months versus 7.2 months for fulvestrant. Again, this positions this drug as a new promising therapy. Another PROTAC in the area of breast cancer was camizestrant. The trial's name was SERENA-6. This was a plenary session. It showed camizestrant plus a CDK4/6 inhibitor extended PFS to 16 months versus 9.2 months for aromatase inhibitor plus CDK4/6 in ER-positive, HER2-negative breast cancer with emerging ESR1 mutations. So again, adoption of this in the real world, we are awaiting the PFS2 data due to similar adverse event profiles, with exception of neutropenia. But again, this is a major advance. Like PROTACs are scientifically cool molecules. We used to see them in mainly the basic science realm. Now seeing them in phase 3 studies and moving on to the real world, again, this is exciting to be, seeing these drugs really, really work. And we have so many PROTACs coming in the future, going after almost every target that we know of. And of course, ADC, the trastuzumab deruxtecan, the initial DESTINY-Breast09 study showed that TXD plus pertuzumab, again, interesting, right? So if we know that TXD, the ADC targeting, with Herceptin and deruxtecan, the ADC with the top one payload, has worked in breast cancer, and now it's approved in a tissue agnostic manner in all IHC 3+ cancers. This, interestingly, they combined that with pertuzumab, and it extended PFS over 1 year compared to the standard of care, which is taxane, Herceptin, and pertuzumab in first-line breast cancer. Again, now ADC has been reinforced in the treatment algorithms in breast cancer. Right. Again, another major practice change in breast cancer was PI3K, right? Again, seeing the theme is targeted therapies, right? Biomarker-driven targeted therapies. Seeing a PI3K drug called inavolisib, which is a PI3K drug. Again, combined with palbociclib and fulvestrant, improved overall survival in PI3K mutated HR-positive lung cancer, breast cancer. Again, I misspoke about lung cancers. Let's move on to lung cancer. We can talk about lung cancer now.
So for breast cancer, you mentioned a couple of these practice changing. Essentially, the theme is the same. It's a targeted treatment, understanding the pathway of how the cancer growth and cancer progression, and really targeting that. But what exciting you the most is these trispecifics, it seems like.
Yeah, absolutely.
Lung cancer, you mentioned, you alluded a little bit earlier to the DLL3 in small cell lung cancer. What else are you seeing in lung cancer?
So again, small cell, right? Again, small cell has been always, lung cancer is the poster child for precision oncology, but small cell, it's been a tough disease. I think, in the next decade, small cell will be like non-small cell lung cancer. Again, we are seeing more and more of novel targeted therapies against small cell lung cancer. I think this is a decade. The last 10 years was a decade of non-small cell lung cancer, and this decade is, I would say, the decade of small cell lung cancer. Again, specifically in small cell lung cancer, we had this drug called lurbinectedin plus atezolizumab. Interestingly, the trial was IM40 trial. The IM40 trial, it was a phase 3 study. Again, it demonstrated that lurbinectedin, which is a selective DNA minor groove inhibitor, an inhibitor of oncogenic transcription, plus atezolizumab as first-line maintenance therapy for extensive stage small cell lung cancer. So this extended patient survival by months compared to just atezolizumab alone. So this establishes as a new standard of care in the first-line maintenance setting in extended stage non-small cell lung cancer. And talking about other lung cancers, right, the combination therapies, we know that we have drugs like adagrasib and sotorasib being approved in KRAS G12C. Specifically, this time with adagrasib, the CRYSTAL-7 study showed improved survival in KRAS G12C mutated lung cancer with adagrasib plus pembrolizumab. So it shows the synergy of KRAS inhibitors with immunotherapy. Why this is important? Because in lung cancer, again, from EGFR, RET, RAS, or ALK, we don't combine them with immunotherapy because most of these oncogene-driven lung cancers are not immunosensitive. But KRAS is unique that patients harboring KRAS alterations do respond to immunotherapy. And this study called the CRYSTAL-7, the adagrasib plus pembrolizumab showed improved survival in non-small cell lung cancer. Again, the theme is, these are in the, later lines, right? Again, but neoadjuvant, again, we need to, I'm a major believer that we need to strike cancer before it starts spreading, right? Interestingly, there was this study called NeoAdora, right? NeoAdora study, which is a neoadjuvant osimertinib study in lung cancer. It explored osimertinib in resectable EGFR mutated non-small cell lung cancer. Again, this showed a major pathological response, which could, in fact, redefine neoadjuvant targeted therapy approaches. So what does it mean?
Wasn't there another trial on neoadjuvant therapy as well in lung cancer that was not osimertinib, or am I missing things? Am I mixing things?
So I think there were a couple of neoadjuvant studies with, the immunotherapy, immunotherapy, but not with OSI. This was the only study with osimertinib with neoadjuvant OSI that was presented at ASCO this year.
So it seems like, to your earlier point, neoadjuvant therapy is almost becoming mainstream. It's already mainstream in many breast cancers, and it's become mainstream in lung cancer, it seems like.
Absolutely. I think this is coming. The theme is coming, right? NeoCast, there was another study being presented at ASCO. The NeoCast study, again, immunotherapy in the neoadjuvant space. I think, we can have a decisive assault on cancer before it takes off. Yeah. I think that's the theme. I think we are more and more seeing, of these neoadjuvant, treatments.
Yeah.
Talking about neoadjuvant, right? In fact, earlier, the plenary session in colorectal cancer, right? The atezolizumab and chemotherapy that was presented by Dr. Frank Syncope from Mayo Clinic, the atomic trial, showed increased disease-free survival in stage 3 mismatch repair colon cancer, supporting immunotherapy's role in adjuvant setting. This is in the adjuvant setting. We are moving on from the neoadjuvant to adjuvant. Again, clearly showing that we need to take it earlier and earlier.
Can we talk talk about this adjuvant one a little bit in colon cancer? Tell me about this. This is stage 3.
Yeah, this is stage 3, but this is specific for a particular type of, a rare type of colon cancer, which is like almost 5 to 7%. It's called mismatch repair deficient form of colorectal cancer, which arises in Lynch syndrome, or it can be sporadic in patients. And this study was a cooperative group study, and this was called the atomic study. And it indicated the improved disease-free survival in stage 3 MMR positive colon cancer, again in the adjuvant setting. So when patients undergo an R0 resection, they gave atezo or atezo plus chemo for a fixed period of time, and then followed these patients.
So
and clearly
some patients
improved the disease-free survival.
Some patients did not get chemo?
Some patients got chemo, yeah.
No, like chemo plus immunotherapy versus chemo alone.
Yeah, chemo plus immunotherapy plus chemo alone, yeah.
The idea is adding immunotherapy to
immunotherapy
is helping in the adjuvant setting.
Mm-hmm.
Very interesting.
But in fact, this trial read out a little bit later than other studies. So again, interestingly, Ipi-Nivo has more advanced data in these patients in this setting. So again, this trial read out a little bit later than the Ipi-Nivo study and other studies like dostarlimab. So again, we will see how long-term this plays out. But technically, again, more and more we are seeing that these patients don't even need chemotherapy. I think immunotherapy can produce dramatic results in patients with this subset of colon cancer. And again, there was another New England Journal paper, right, just a month ago that was presented across dMMR positive cancers, showing that durvalumab, not dostarlimab, showed significant activity in earlier in the neoadjuvant setting in colorectal cancer. Again, the message is we need to take it earlier and earlier,
sure,
so that we can have deeper cures, more cures, and more responses in patients.
For deficient tumors in this trial, it was chemotherapy plus IO versus chemotherapy alone. Was there an IO alone arm?
I need to check that. I don't remember exactly, but again, definitely I can check that and get back on that. Yeah.
Yeah, because that would be interesting to your earlier point.
Yeah.
Are we able to avoid chemotherapy in a subset of patients? Speaking of adjuvant therapy, there was this big study, the challenge study, that talked about exercise. So as a clinical trialist, Vivek, do I really need to prove that exercise is good? I mean, I don't want to, we can go through the trial and so on, but exercise is good. Like, why do I need to spend so many resources to prove that exercise is good? I mean, I've been telling my patients to exercise since I was in residency. I'm not really sure what, I mean, I'm glad to see the results and the positive results and everything. Don't get me wrong, but I almost said, well, duh, of course it's going to be good for you. I mean, even if it's well, let's assume it did not improve overall survival. I'm going to still tell my patients to exercise. So the null hypothesis is not going to change what I would tell patients.
I think, it was important that the study was done and it was at least shown that exercise improves that. Think about it, right? If exercise was a drug, like let's call it an exercisimab, this would be approved.
Yes,
if this drug was approved, insurance would pay for this. Insurance would pay for gym memberships.
That's what you're talking
right?
about. You're going after.
Exactly. Insurance would start paying if this was a drug. This was a standard of care. This was in HCCN guidelines. Then insurance companies or whoever is providing your insurance, your employers, would cover for gym memberships, right? So that one, again, exercise could have cancer prevention.
By the way, it was a very tough exercise schedule. I don't know if you got a chance to read the actual exercise program that they had and the training.
Yeah.
No, it was not an easy exercise program to follow. Like, it did require a lot of attention for a couple of years. So I see what you're saying, though, that there was.
No, but I hear your point, right? I think exercise is important. Again, I don't know. Again, many cancer patients, right? We tell them to exercise, but there is no prescribed regimen for them, right? If it's a chemotherapy, a drug regimen, or something, they would follow that.
I guess it's a philosophical thing for me.
Yeah.
I'm trying to think. There are certain I cannot do everything with randomized controlled trials, and if I like, there are certain things that are common sense in my view. you're always going to tell people exercise well, watch your diet, do your best. Like, I know, like, I feel I'm not taking anything away from the authors, the investigators, or the patients. It's a very commendable work. And like you said, if this was a drug, it would be approved. I'm just questioning, do we need to study things that I view, and maybe many people also view, as common sense? Let me throw an example to you. Um, let's say Dr. Tony Schwery, our friend, says he wants to study if exercise improves survival in adjuvant therapy after resected renal cell cancer in high risk disease. Do you think we need a study like this?
Again, certain studies are common sense, but it's at least reassuring to know that someone did the study and it is there, right? There are different funding mechanisms to get that done. And again, it's an important question, right?
Yeah.
So it's an important question to know for patients that, hey, by the way, exercise, has benefits for overall survival. So the question here is, would exercise be prescribed as a regimen for patients with cancer? Should cancer centers open gym units for patients with cancer, just like chemotherapy infusion centers? Right? Again, many patients, may not have the time at home or in their workplace to do exercise. The question is, they go to the oncologist prescribes 1 hour of exercise, and would that insurance cover that time?
Yeah.
And if that oncology system starts billing, then it will be a big thing, right? It will force it. Again, things always, if you force functions, things happen. Just say that, hey, follow a healthy lifestyle, go to the gym. That's it, right? How many patients will follow that? Every time I don't go to a primary care doctor, but if I meet a friend who's a primary care doctor, right, who says, hey, follow a healthy lifestyle. What do you mean healthy lifestyle? Right? In this day and age, with so much of travel and everything, healthy lifestyle
my guest is not practicing what he's preaching. Well, so I think this will actually, I'll be very interested in real world data on this. Now, since the publication of this study, I would love to actually take a peek in about a year and do a retrospective analysis of real world data of patients with resected colon cancer and have just a questionnaire, like a case, just try to ask if people are going to the gym.
Again, I think the data probably already exists, not just resected colon cancer, for every cancer. I think all these devices, the Apple Watch we wear, the iPhones we wear, should track activity, should track the steps, should track everything, right? These are
everything, trust me.
They track everything, right? So these are digital endpoints. I don't think so we need a randomized study for that. But what essentially, Shadi, to your point about this can be a real world evidence data showing that, hey, tracking this helps. Maybe the insurance will cover your Apple Watch.
Yeah. Oh. I think if there's any insurance executive listening to this, they're gonna say boycott Vivek. He's gonna make us pay for the gym membership, Apple Watch. So okay, we talked about new drugs, the trispecifics. That's interesting.
Yeah.
We talked about neoadjuvant. We talked about adjuvant as two themes. Anything in the molecular world, MRD world, ctDNA sequencing in that particular area that piqued your interest at ASCO?
Oh, absolutely. I think a lot, right? A lot of, tons of MRD data being presented, a lot of cfDNA clearance data being presented. Again, we usually use, RECIST-based measurements, right? When we see the waterfall plots, it's all the percentage of tumor shrinkage in bulky disease. We are seeing a lot of vaccine studies being presented in the adjuvant setting. So how do we follow the responses signals of activity of these vaccines in the adjuvant setting where there is no disease? MRD comes into play. Circulating cell-free DNA comes into play. So if they are, MRD positive, meaning they have a minimal residual disease positive, those patients are given vaccine. Say, for instance, let's pick KRAS vaccine, and then they are followed over time. Right? Previously, before the advent of ctDNA or cfDNA and liquid biopsy technologies, we used to measure only the relapse-free survival time for these patients. Now we can objectively measure, and track these MRD, track these, cfDNA time points to see when they actually start progressing beyond the conventional tumor markers. I think, the 2025 cfDNA technology is much, much advanced than what we had like 10 years ago. Again, not just for, we are using them for diagnosis, for prognosis, for monitoring disease, for also looking into resistance mechanisms. So many studies were presented to look into resistance mechanisms from KRAS targeted therapies, from many, many targeted therapies. Again, ASCO was full of all these abstracts showing the mechanisms of resistance on target and off target to using ctDNA technology.
Are you? I know you do almost 90% of your patients on clinical trials, but in the patients who are not on clinical trials, are you seeing MRD now being mainstream in solid tumors?
It's still, it has a lot of way to go, right? Because, I work in a referral unit where we see a lot of patients. Many times, I think patients get it once, patient gets it twice. I don't think so. The oncologists, again, are using it the way it's supposed to. The main area where it's being used is to, mainly in lung cancer and many other cancers, right? To look into for targeted therapy options, and also serial monitoring for, looking into acquired resistance. So, yeah.
Any other things that piqued your interest at ASCO? Any other
Again, talk about AI, like tons and tons of sessions on AI. Right?
AI, my favorite.
Yeah.
Topic. Yes.
Exactly. Tons of sessions on AI. In fact, ASCO and Google Cloud, the CEO of Google Cloud, Thomas Kurian, and CEO of ASCO, Dr. Cliff Huddis, had a nice model. There was AI integration. They launched an AI-powered ASCO guideline assistant. Again, it's so hard, right? With unprecedented advances in oncology, it's humanly impossible, as we discussed earlier, to keep track with everything. So ASCO guidelines assistant, they're using a Vertex AI and Gemini model to enhance access to evidence-based guidelines. Again, this is a step towards responsible AI use in oncology. Again, thinking about use cases in the real world of oncology, looking into the guidelines, ASCO guidelines, I think we'll see how this pans out. But I think this is so exciting to see how AI can assist oncologists by streamlining all the application of these very complex guidelines from ASCO to enhance clinical workflows and patient care. And again, think about that, right? A regular oncologist is seeing at least anywhere from 25 to 30 patients, 2 breast cancer, 2 colon cancer, 1 myeloma, 1 leukemia, 1 sarcoma, many, many tumor types. Where is the time to look into all the guidelines one by one? Again, AI can, help, right? So ASCO also updated its guiding principles in oncology, right? AI in oncology to reflect AI's role. Again, there are multiple radiomic studies, right? There was something called onco.ai. It was a deep learning radiomic model that was presented, and serial ctRS model was presented. It's called a deep learning radiomic model series. It's called serial ctRS, and they validated that. There were several retrospective studies showing image harmonization of PD-L1 for immune checkpoint response. And interestingly, there were a few studies presented for clinical reasoning, AI in clinical reasoning. Study evaluated a large language model like GPT and Claude Opus using 273 breast oncology multiple choice questions from ASCO QBank. This was focused on clinical reasoning, not just accuracy. GPT-4 achieved an 81.3% accuracy, right? And Claude almost 79 to 86% with prompting, and showed enhanced reasoning. Again, think about that. In a year or so, I think you could almost get it to almost 99%. So interestingly, this shows, Yeah,
I agree with you.
Yeah. Again, it also shows broader AI trends, right? So future role in cancer prevention, combining AIs with AI technology, a lot more in trial design, a lot more in early detection, lung cancer screening, leveraging AI. Again, many studies being presented, AI in melanoma diagnosis, right? Again, what they say is many countries, and again, there was always a critique that AI can be implemented only in the developed nations, but many LMICs are embracing AI faster than the developed world because they don't have any legacy systems in place, and it's cheaper, right? They may not have a radiologist in many countries.
Yeah, absolutely.
Yeah.
Going back to your tweet from June 3rd, you tweeted about 10 NEJM papers published simultaneously, all practice changing. One of them is the one you mentioned, the tarlatamab in small cell lung cancer. We talked about that. We talked about this one. We haven't talked about adjuvant cemiplimab or placebo in higher cutaneous squamous cell cancer. That's very interesting as well. And then one about breast cancer and the vasomotor symptoms, and the durva, perioperative durva in gastric and GE junction. Any thoughts on this one?
Yeah, that was an interesting, definitely the perioperative durva was a very interesting study. And I think what essentially they, showed was, I remember it, it's a Matterhorn study, right? Was it the Matterhorn study?
Yeah, it's basically the Yelena Jani.
Yeah, that is a Matterhorn study. So it's a durva plus FLOT, right? So Matterhorn phase 3 study, it was present plenary session. Durvalumab is an anti-PD-1, FLOT is a chemotherapy. It was followed by, I believe, surgery and durvalumab. It improved the 2-year event-free survival to 67 versus 59% for neoadjuvant GEJ. Again, talking about neoadjuvant, right? FLOT alone were unresectable GEJ and GE junction cancer. Again, it also panned out for overall survival for 2-year overall survival. Again, they positioning D-FLOT, durvalumab FLOT becomes a new standard of care.
And the neoadjuvant, the Patrick Ford study, 3 cycles of neoadjuvant Nivo plus chemotherapy improved overall survival. This is like the holy grail, like overall survival.
Yeah.
And we covered the other ones, exercise, and I love the exercisumab. I like that. That's a very nice thing to do. And we talked about all of these. I love these themes. We talked about neoadjuvant, adjuvant, newer therapies, molecular stuff, and AI. These are 5 major themes. Did we miss any theme from ASCO 2025? And anything specific you're looking forward to ESMO 2025 as you head there in the fall? Because we'll do a Vivek's Take after ESMO, but what are you looking forward to ESMO?
Again, ASCO was fantastic. Maybe since we mentioned Tony, we probably need to mention something in urothelial bladder cancer as well. So the EV, the enfortumab vedotin plus pembro, which is now standard of care, showed the data that showed doubled complete response rates in advanced urothelial cancer carcinoma, right? I think that was very, very interesting and exciting in frontline bladder cancer. So looking forward for ESMO, right? ESMO 2025 is going to be in Berlin. It's going to be fantastic. It's going to be a great meeting. Again, what was not, again, there are some trials which are going to mature during ESMO, and that will be presented. It's going to be exciting. Again, interesting to all. Again, there are going to be always amazing scientific tracks with breast cancer, the metastatic breast cancer, GU cancers. All tracks are going to be fantastic. There's going to be a special track this year. Again, it's going to be the tissue agnostic track. Again, I thank Dr. Fabrice Andre and, of course, Dr. Tony Shori and Miriam Shalabi for, allowing this tissue agnostic track, and have the pleasure and honor to chair this for the first time ever in a big meeting, tissue agnostic. And I think that's a way of the future. Today, we have at least 10 drugs approved in a tissue agnostic space. And, hopefully in the next 50 years, we'll have 100 drugs approved in the tissue agnostic space. So again, ESMO is going to be exciting. There's going to be another session on AI and oncology at ESMO. So again, 2 now new sessions being added on at ESMO. ESMO is going to be great.
Well, I look forward to both sessions. And Vivek, thank you so much for giving us Vivek's Takes. We titled this, Report from the ASCO 2025 meeting. Really, thank you so much.
Thank you. Thank you so much. As always, a pleasure.